Okay, so over to you, Alan, for your first case.
Thank you very much. Thank you so much for having me. I've been tasked to talk about COVID and asthma, the lessons and the learnings from this pandemic. You all recognize the coronavirus there, and you understand the name of it came because it's shaped like the crown of a king. So that's where this name came from. So I thought I'd go through a case together with us as we go through COVID and the alphabet of different viral variants that we've had through times. So in 2020, this 45-year-old moderate asthmatic who was well controlled on a moderate dose ICS-LABA as well as a LAMA and a SABA PRN with a reasonably normal lung function, FEV1 88%, although interestingly giving him more medications actually did not improve that lung function. He's been exacerbation-free for 3 years. He uses a SABA a couple times a week, if that, usually for exercise. So we would define him as being controlled. He never wakes up at night because of his asthma. But he was very worried about this COVID alpha wave, and he heard all kinds of noise about how steroids might worsen the COVID effect, and it could worsen his risk of getting COVID. And the immune problems seems to be the issue, with immune issues causing the problem with COVID. And don't the steroids worsen immunity? And in fact, he was so worried about this that he, like many of our patients, actually stopped their inhaled steroids because of the concern about this. The first, of course, is we all know that the relationship between asthma outcomes and treatment is very clear. The more ICS you use, which is on the right, the less exacerbations you have. And conversely, the more SABA you use on the left, the worse the outcomes are. So clearly for a patient like this, stopping their inhaled steroids and continuing just SABA could be disastrous. Then there was a bunch of data, and although this is a more recent publication, it dealt with the first viral outbreak, and they looked at outcomes of asthma in people in Scotland. And what they found here very clearly is looking at the people with just asthma alone, without severe asthma, no oral steroids, actually did not have a higher incidence of COVID and had no increased incidence of more severe COVID. But there was an issue of people who were on oral corticosteroids. So if they're immunocompromised with the oral corticosteroids, they're at risk. But even stopping oral steroids is recommended against, because that could put them at risk for worsening asthma as well as adrenal suppression. So again, we recommended not stopping even the oral steroids, but reducing it if possible. So that was really the concern, those people who were really immunocompromised on oral steroids, but not the everyday asthmatic, even a moderate one like this. And then soon afterwards, there was work done with the STOIC in the principal trial that looked at the use of budesonide, 800 micrograms twice a day, to attenuate the effect of COVID. And what it actually showed, if you compare it to usual care, there was a much faster recovery, higher likelihood of recovery in those groups that actually had budesonide treatment versus those that didn't. So in fact, it was clear that the use of inhaled steroids may actually be a benefit even to the non-asthmatics to prevent worse outcomes for the COVID.
And Alan, there was this concern about inhaled steroids and how they work, and I see you've put up a slide on the ACE receptors. What exactly happens? Is it the ACE receptor that gets upregulated or downregulated? How does the inhaled steroid really protect against COVID, or is that still not known?
Well, there's a lot of theories to that, but I think the one that makes the most sense here is that the spike protein has to attach to the receptors in the lung. And it seems that to the ACE2 receptors in the lung, and it seems that inhaled steroids actually downregulates those ACE2 receptors in the lung, therefore making less points of attachment and hopefully therefore less bad outcomes in terms of the COVID. And this was actually shown also when it came to nasal steroids. This article in JAMA sort of looked at people who were or not on nasal steroids. And you can see here in the top left corner, the group of people that were actually on nasal steroids had better outcomes than people that were not on nasal steroids for other conditions. So it appears that the spike protein can attach anywhere in the airways, whether it's the nasal epithelium, into the upper epithelium, or into the lung itself. And by having the inhaled steroids decreasing that ACE transmission and attachment, we decreased COVID outcomes. So this gentleman went back on his medications. He continued to be controlled. He did all the non-pharmacologic treatments. He used social distancing, used a mask, although he didn't like it, and he remained COVID-free. And of course, this was prior to vaccinations, of course. So he stayed lucky in the alpha wave. He did not get a COVID infection or a bad COVID situation. But of course, as we move through the alphabet of variants, then came the Delta variant. As you recall, this seemed to be a little bit more virulent. It was first reported, at least in Canada, April 2021. And it became quickly the dominant variant both here as well as around the world. And of course, you in India know this very, very well. And then the vaccinations sort of came. And in Canada, we first had the AstraZeneca vaccine, then the Pfizer vaccine, a little later, the Moderna vaccine. So then we had people who, of course, wanted these vaccines as soon as possible. But because of supply issues, we had to have very significant risk stratification for who should be getting the vaccine. And the vaccines were being given, of course, to people who were older, people with immune issues primarily first. And of course, according to this man, he says, well, I have asthma, so why am I not high risk? And he was actually very upset that he actually could not get a vaccine. So I explained to him, of course, that that's not the way this goes in a time of not enough supply. So is the elderly, the immunocompromised, people living with housing issues like the indigenous or in older age homes. And then a little bit later, that followed with chronic illnesses like heart failure, COPD, and diabetes. But asthma, because of the data, it actually did not show that asthma was a high-risk group for contracting COVID, or in fact, for more severe COVID either. So with that explanation, he went away not very happy, but subsequently he did get vaccinated as soon as he could. The first vaccine we had available in Canada in good amounts was the AstraZeneca vaccine. He was eligible for that, and he got his first one, and then he came back to get his next one at 12 weeks, which was the timing that was recommended in Canada. However, he was a little frustrated, but he kept taking his medications. He stayed controlled. He did get vaccinated as soon as possible. Well, then time marches on, and we move on to the Omicron variant, and this made it to Canada in the end of 2021. And I think we all recognize this is a different animal. It had more than 30 variations in the spike protein, which made it actually more transmissible. The big question was it less virulent? And it probably is a combination of being somewhat less virulent, as well as a significant part of the population getting vaccinated. But even in South Africa, where this first was actually shown, the death rate was much less with the Omicron than the previous variants, although of course a lot of people at this point had COVID as well. Well, with all of this, a lot of people were getting what we called COVID fatigue. They were tired of the social distancing, they were tired of the masking, they were tired of staying away from family and friends. They missed things like sporting events and restaurants. And he's wearing his mask, and he did keep to it a lot, but of course, people just got tired and stopped being quite as careful, and some of the restrictions were left. So why was that? Partly because of data like this. And if you look at the Delta variant on the left, you can see there's lots of hospitalized cases, lots of people in the ICU and the ventilator. If you compare that to on the right with the Omicron situation, lots of infections, some people still got hospitalized, but many less that ended up in the ICU and on a ventilator. And it appears also about Omicron that actually it tends to infect the upper airway more than the lower airway, which may be another one of the reasons why it's not quite as severe of a variant.
Were there any differences between these two waves in the asthma management, particularly, Alan, and then Louis-Philippe?
Well, any virus can precipitate asthma exacerbations, as you well know. Right. But I don't think that was really the big picture here. The big picture here, of course, with COVID that was different than other things that previous SARS viruses, of course, was that you're infectious before you actually got sick. And the other big issue with Omicron is you're infectious and not necessarily sick. So that became a big issue in terms of being careful. And for me personally, I had started opening up to do spirometry and so on in my office again. And I had to shut that down again because, of course, everybody could have Omicron, and sort of testing everybody all the time be very difficult. So we put the spirometry testing on hold in our office, and we're just going to start opening that up again right now as the numbers are falling. Louis-Philippe, what happened with you?
That's great. The spirometry opens up another Pandora's box. But Louis-Philippe, please.
Well, yeah, that's very interesting. In fact, I guess we initially we were very concerned about asthma exacerbation, but as we said, in fact they had less asthma exacerbation, and in fact the flu season was almost negative. There was nothing, so we were confident. But with the relaxation of the measures with the Omicron, people were not as good at the public health measure as before. Surprisingly, it's not the COVID that gave the problem, at least in my practice. It was mostly the other viruses. In fact, when people were not wearing masks or paying attention to contacts, they were getting other types of viruses that make them exacerbate. So surprisingly enough, it was not really the Omicron that was the big problem. It was the other types of viruses. But of course, we were concerned about the immunosuppressed, those who were on oral corticosteroids, although there are not many of those. But then we insisted on the measure in these patients, and it went well.
And that's fantastic. Excellent perspective from both of y'all on this issue. Just one question to you, Louis-Philippe, on spirometry. So what's the current guidance, Louis-Philippe, in your department?
Current guidance is that when the patient come for a spirometry, they test themselves. It's not the PCR, but the other test that is simpler that they can do at home. And if they are positive, of course, they don't have the test. If they are negative and they don't have any symptom, they can come to the lab to have the test. But of course, the precautions are taken by the personnel with the mask and the blouse and everything, to be sure that with some air movement also in the room, to be sure that we don't disseminate the virus in case they have some.
Please carry on, Alan. Please.
However, with all this, this gentleman then ended up getting sick. He had a bit of a cough, and he said, "Well, listen." He at this point he was triple vaxxed, so he says, "Well, I can't have COVID, can I?" But he did have a fever, and he was a little bit more, getting to be a little short of breath. But this cough was the bothersome thing, first of all. So he didn't have any loss of smell or taste, which, as you know, was a common issue with the Alpha and the Delta, but much less common with the Omicron. So he got a COVID PCR. It was positive. So yes, he's infected with likely Omicron at this point. And of course, he was very scared. Remember from the beginning, this guy was very worried about this from the beginning. So now he says, well, am I going to die? And I don't want to die. So what can I do to end up not being in the hospital? Because I think there's some treatments now for COVID, isn't there? Which of course there wasn't initially. So the question then was, is he high risk enough to get some of the very expensive new treatments? Or what are the combinations there? So there are some monoclonal antibody therapies that are available. We have one currently in Canada, sotrovimab. There's many others available in the United States and other places. But the list of people who's eligible for this is kind of restricted in order to be able to keep supply. Recently, we have the combination antiviral oral pill called Paxlovid. It just got approved. We don't have supply of that just yet, at least on a routine basis. So he wasn't considered high risk enough, and there's a set of criteria for both of these. So in primary care, when these people are not sick and they're not high risk, what are our other choices? So in this particular case, however, because he was already on triple therapy for his asthma, there really was no evidence for adding on budesonide on top of that. So with no evidence, we decided to go the trial of fluvoxamine. Here's the dosing, as I mentioned, 50 milligrams a day for a day, then 100 milligrams twice a day for 2 days, then 100 milligrams 3 times a day for 15 days.
Have you, Alan, seen an uptake in the inhaled steroid usage during the pandemic? Because we've seen a huge uptake in acceptance of inhalers and inhaled steroid use. Have you seen that in Canada as well?
We've seen it in Canada, and actually it's been published in many places around the world, that people were much more adherent to their medications for both asthma and COPD than really ever before, because they were afraid. And therefore they said, I'm going to take my medication because doc said I need to keep my illness there because that's the best thing I can do for my COVID.
Another reason to improve adherence, COVID. Just imagine, we would never have thought of that earlier. Please continue.
It actually helps some other things as well. Smokers, for instance, were also known, at least in the Alpha and Delta waves, to have a much higher risk of having more severe COVID. And it became something to actually get people to quit smoking as well. Wow. So, even though this has been a disaster around the world, there's actually been some silver lining. Yeah. And so I just wanted to show that, this sigma-1 receptor agonist endoplasmic reticulum chaperone protein, which is different in fluvoxamine than others, is really why you can't just replace one antidepressant with another. So he did this and he recovered, and then he was concerned, well, okay, am I going to get long COVID? And of course, now there's a lot of noise about long COVID and people not recovering for that. So he said, well, what do I do to prevent long COVID? Should I get yet another vaccination? Is there anything else I can do? So I just thought I'd share with you an article, first authored by a friend of mine, Rupert Jones from the UK, that looked at those people that we could sort of predict the likelihood of getting long COVID based on their situations. And you can see, obviously age and a little bit more for the female sex, and for higher BMI, and smokers were higher, and frailty, which was a higher risk. But in terms of respiratory illness, we look at asthma and COPD. The increase in asthma was very small there. You can see it does cross 1, so that wasn't very impressive. COPD, on the other hand, was a little bit more impressive.
And so superb case, Alan, a lot of learning points there. Thank you so much.